Please, friends, if you have any questions, I will be happy to answer. So with resection we finish, yeah, and we come to cholecystectomy. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 15. 4 absents, tell me please.
Aswani Brain.
1 minute, wait please. Aswani 6-1 absent. Next.
Brain.
Brain 7-1 absent.
Fatima.
Fatima, it is 18 and one more.
And Steffi.
Sorry?
Steffi.
Steffi 70. All others here, yeah?
Yes.
No any questions? If no questions, let's continue, guys. Today we will finish earlier. I will not start to introduce you anything new. So after I will finish, you will just sit down and wait until the time will be finished, or you can ask me the questions. Why I don't want to start the new topics? Because everything will be mixed in your head. Let's finish this one to right control, and only next week I will introduce for you lumbar region together with retroperitoneal space. Time is more than enough. During next week I will finish these 2 topics. One more week I will need for pelvis, and all another times we will study the lower extremity. This is the big really region. Yeah, one by one, from up to down, we will study it together. Now, attract your attention to me. Next surgery, which I will discuss with you, it is the cholecystectomy. If I will just translate this term to English, it will be complete removing of the gallbladder. As usually, we start from indication. Friend, I don't understand. It is start to little bit make the problems for me. Why the same person every day, every my class should come later? I'll take my helicopter. Come sit down. The class. Do you think that I really use the helicopter? If you will find it, take it to yourself. What is indication? Because any treatment must be indicated. Usually you say it is the inflammation of gallbladder, but it's not so. Because inflammation usually treated by medicines. But if it is complicated inflammation, complication usually if it is gallstone disease, in that case we need to make cholecystectomy. Why? Because stones can make obstruction and to make mechanical jaundice. More of this. Stones can perforate the wall of the gallbladder and to form the peritonitis. More of these. Like complication of this problem, we can have the empyemas, pus formation, for example, abscesses, cholangitis, choledocholithiasis, abscess of the liver. That's like all these to prevent these problems in case of complicated inflammation. By the way, it can be acute or chronic. Do you know what the difference? In case of the acute gallstone disease, we have complete obstruction of the bile ducts. In case of the chronic form, we have non-complete obstruction. Some amount of the bile can flow, but it's not enough to the normal. That's like hypertension inside of the gallbladder, hyperconcentration of the bile, because as you know, inside of the gallbladder, it's not only stored, but it's also concentrated. By the way, abnormal concentration usually gives the sedimentation and formation of the stones. It can be pigment stones, it can be calcium stones, it can be bile acid stones, different kinds. Okay, causes of the problem, by the way, can be different. Usually, mainly, it is the acute inflammation, which is come to the chronic one. then it gives the sedimentation and formation of the stones, and finally it can give or obstruction or perforation or all another complications which I told you. You will have the special subject which is called surgical diseases and etiology, pathogenesis, signs and symptoms, and anything else we will study in the future. Now it's not my goal. My goal is to explain for you how we make the surgery. And any surgery started from its success. About position, I don't speak. Of course, it is in back. Of course, we use the general anesthesia, usually intubational anesthesia, because we use the long time for the manipulation. Usually, it is from half of hour up to 1 hour, comparable with the situation. And then you make access. You can do two types of techniques. You can make open surgical access. You can make endoscopical access. But anyhow, despite the technique, your access will be in left hypochondric region. Because from left hypochondric region, you can become to the visceral surface of the liver, which is contain the depression of the gallbladder with the gallbladder. In case of endoscopical access, two perforations located in hypochondrium, one in the region of umbilicus. By one, you inserted endoscopical equipment. By second two, you inserted manipulators or micro instruments. Yeah. First of all, you made peritonization. You injected the air inside of the peritoneal cavity to separate the structures from each other. Technique of surgery will be absolutely same for both techniques, and for open one and for the endoscopical one. Let's finish to speak about access for open. You remember classical cochlear incision. It is along the right costal argent, one finger below it. Or you can make combined incision. For example, incision of the Fedorov. You started by a cochlear incision, then you make, for example, pararectal incision. Continue it to downwards. You need to do it if the normal anatomy is not kept. If we have dense threads, abscesses, anything else which is destroy the normal appearance of the region, and the line is not enough for you to recognize and to make revision. Instead of the line, you make now flap-shaped form of access, much more wider, which gives for you more revision. Anyhow, then accesses happen. You come to the inferior margin of the liver. You apply usually the hooks. You retract the liver to the upwards. Let's say it gives the ventropedal position. Then you push inferior margin to upwards. Visceral surface come more to you. You see the fossa vesicephalae. As you remember, it is the depression which is located in the visceral surface. I don't know, is it shown here or not? Yeah, you can see portionally it is removed. Anyhow, you can see this fossa vesicephalae, which is occupied by the gallbladder. I want to remind you that your gallbladder, it is mesoperitoneal structure. It is covered from down. It is covered from sides, but it doesn't cover from upwards. Upper wall, it is attached to the liver. And between liver and gallbladder, we have very thin connective tissue layer, and it gives you a chance to make separation of these structures from each other because they doesn't fuse. We have a loose connective tissue. By the way, fundus of gallbladder, as you remember, is intraperitoneal. It's covered from all the sides. From all the sides. So remember, please, two longitudinal grooves. Right one, it is the round ligament, venous duct ligament. Left one, it is the gallbladder depression and inferior caval depression. So we work in the left. In the right longitudinal one. Left one, it's located a little bit left to this one. Okay, now I must make the choose between two techniques. Technique one we call neck first. Technique two we call fundus first. Of course, guys, etiologically neck first method is better. Why it is better? Just because primary you ligated main duct and don't have any other bleeding during all your surgery. Go to my room and in front of my table, take two different colors of the markers and come back. Let's say from that point, it's better. But to tell the truth, it's a little bit more dangerous. Why it is dangerous, guys? Because you must open and cut the hepatoduodenal ligament, which is contain a lot of important structures. Of course, you will open this ligament maximally proximally. It means near the hilum of the liver. Because the more distally you will go, the more structural units will be inside of it, and the more will be the chance to damage the structures inside. Don't forget about the most important three structures, which we call portal triad. Yeah, DVA, ductus coledocus, vena porta, arteria hepatica. And you must to find so-called, thank you very much, Calot triangle. You remember many times, thank you very much, many times we discuss and spoke about that. This is your gallbladder, this is the duct of the gallbladder. From upwards in the hilum of your liver, located left to the fossa mesencephaly. Yes, you understand. It's located between right and left longitudinal grooves. Yeah, it means the H-shaped groove. Let's say we are now inside of a right groove, left to the right groove. In the perpendicular position, we will have hilum of the liver. From the hilum of the liver, two ducts is originated. It is right and left hepatic ducts. They join to each other. They form the common hepatic duct. Common hepatic duct comes to your hepatoduodenal ligament, join the cystic duct, and together they form the supraduodenal portion of the colon, which is located inside of the hepatoduodenal ligament, the same DVA, which I mentioned for you before. You must to find these triangle together with these arteries. As you remember, inside of the same hilum of your liver, proper hepatic artery split it into two branches, and right one gives the cystic artery, which is come to the gallbladder and supply it. And that is triangle A, which is called the Calot triangle. So you will do your best to find inside of hepatoduodenal ligament this Calot triangle. Unfortunately, friends, if the normal anatomy is changed, for example, if there are here abscess, or if there are the dense threads, yeah, it will be not so easy to recognize normal structural units inside of hepatoduodenal ligament, and will be big chance to damage them.
Yes.
In that case, you will avoid this method and will use technically more easy method, which is not so correct, which is called fundus first method. Fundus first method technically is easy, but it needs long time. Because instead of ligation of main artery, you will ligate many branches of it. But what will be consequence of my work? It is not big diameter artery. Let's say usually you apply only two arterial ligatures, one in proximal end, one in distal end. Between you cut artery, let's say you make the ligation of the main artery. During all another your manipulations, no any drop of the blood, because you ligated main artery. I think it's understandable for you. What next? Next, what should I do? I must make the work with cystic duct. How I do it? Approximately half of centimeter up to this bifurcation, I apply arterial forceps. I little bit crush the wall of this bile duct, and then I remove the arterial forceps, and in this place I ligated the duct. Why not immediately the ligature? Because if you will make hypertension, you can cut the wall of the duct or damage it. That's why we prefer to little bit crush it to make the groove. And then to apply inside of the groove the ligature and ligate it. That's why length of this stump, guys, will be half of centimeter.
Yes.
Above it, you will put arterial forceps. Now between ligature to prevent the leakage of the bile, after cutting. Now between ligature and arterial forceps, you will cut the duct. It means you make the separation of the neck. Neck is separated. Now, guys, by these arterial forceps, you will start to lift step by step your gallbladder to upwards. Using the toofer bluntly, you will start to make separation of it from the liver tissue. By the way, if it is old problem, we can have connections between liver and the upper wall because it's happened due to the sclerotization usually and vascularization. You can find some vessels here also. Don't worry guys, main artery, it is ligated. That's why just cut them and go up. It is understandable. How much you will go? How much you will go? Up to reach the fundus. But before to make it, of course, from two sides, you take the scalpel, you cut it this peritoneum, which is fix the gallbladder into the liver here, and you start to make bluntly separation up to reach the fundus of your gallbladder. Then fundus is, so you cut the peritoneum from two sides, yeah? Usually we use scissor, yeah? We inserted scissor, we cut it up to the fundus, and in the region of the fundus, we cut it surrounding, because fundus cover from all the sides. You remember, yeah? After this, guys, you will achieve the empty fossa vesicephala. What we need usually, two manipulation. Number one, I inserted the drainage tube, which is removed by contour aperture, not main incision. Number two, I make peritonization. I suture these cutted two margins of the peritoneum to each other. That is necessary to prevent formation of the dense threads, fibrin, because damaged peritoneum, as you know, productive fibrin. As I to prevent it, usually we make the peritonization. We try maximally to cover the surfaces by the peritoneum. That's all. In case of the fundus first method, all consequences opposite. First of all, you cut the peritoneum from two sides. Now, starting from fundus, you bluntly separated gallbladder, but you find a lot of the branches of the cystic artery, and each branch must be ligated or coagulated. Comparable, if it is small, we coagulate it. If it is middle one, we ligate it. How much? Until you will come to the same triangle. All another your steps here will be same. You will make the ligation of artery, you will make ligation of the duct, and the incision of it. That's all. You know, guys, what is the benefit of this method? You don't need to find anything. You will come to this triangle. Because continuously your gallbladder become to this triangle. In case of duct first method, you must to know very well topographical anatomy. You must be responsible to find this triangle primary inside of the hepatoduodenal ligament. Of course, it is not easy, but you must have knowledge, but you will need a shorter time for the performance. Because then you ligated main artery, all your next steps of surgery is very simple. You don't need to waste your time to ligate it many branches, because main artery is ligated. Usually, guys, it's very important to track the tension into the stump of this gallbladder. We try to not leave a long stump, but at the same time, we try to not make ligation from the root of it. If you will leave longer stump, 1 centimeter or more, we can have in the future formation of false gallbladder. Sometimes you say, great, let's achieve the new. No. This false gallbladder in 100% of cases will be inflamed and possibly perforated. It is not the normal gallbladder. We must do our best to prevent. Why we don't ligate it from the base? To not make the narrowing of the main ducts. Because if you will make ligation in that level, in the level of the root, you can easily, not complete, but you can make some portional obstruction of the bile ducts. They say half of centimeter, that is 5 millimeters, It is the gold standard. Not more and not less, usually 5 millimeters, it's more than enough. It is not enough to make false gallbladder, but it is enough to not make any obstruction of the bile ducts. It is understandable. Yes. Possible complications, guys. Leakage of the bile inside of the peritoneal cavity if you don't properly ligate it. very dangerous situation. It gives so-called bile peritonitis. Damage all the phospholipids inside of the peritoneum, huge production of the fibrin and formation of the strangulational disease. Then different parts of gastrointestinal structures fuse to each other. Bleedings, of course, if you don't normally ligate it, that's why we insert it anyhow, drainage. Drainage is necessary to evacuate it all possible liquids which will be accumulated in fossa vesicephala. Usually in second, third day, if we see that it is empty, we just turn it back and remove it from wound. It doesn't need to make any suturing, anything else. You just remove maximum one suture you apply in this contour aperture, nothing more. But it is very important to remove it from contour aperture, not from main incision, because it's not sterile. If you will remove it from huge incision, it can give the infection of it with the future a lot of problems. Say 5 centimeter far, make the contour aperture, for example, in the belly. And through this aperture, remove this rubber tube to outside. By the way, after you can use active drainage or passive drainage. Active, it is usually unnecessary. Then you connected it with some sucking vacuum machine. It is removed by the power. Liquid makes negative pressure, and liquid comes to outside. And passive one, that just by the difference between environmental and internal pressure, liquid is evacuated to down. Of course, you descend it to down to provide the gravity powers from up to downwards. And liquid is leaked to down and collected in some bottles. And time to time, if you see, for example, hyperproduction, you must make the pathological verification. What is it? Is it blood or is it bile or what? Because according to the situation, maybe you will need to make real appendectomy. Usually it's not necessary if you don't make mistakes. But for example, if you don't normally ligate bile ducts and you see that a lot of the bile is come out. So this is very serious situation. Do you have any questions about this? If not, let's continue. Last what I want to explain for you guys, it is the appendectomy. Name is show the purpose. You remove appendix vermiformis. This is the process which is located in cecum we study together, and which can be inflamed. Inflammation we call appendicitis. By the way, more than 90%. It is acute form of the inflammation, very rapid. From start up to the finish, we have usually hours, maximum day. What does it mean start? Start, it means process is started like the catarrhal inflammation, otherwise serous inflammation, no any pus. Then it comes pathologically to the phlegmonous form, formation of the pus. Then it can come to the gangrene and necrotization with the perforation. Then appendix is perforated, content become to the peritoneal cavity and it forms the peritonitis. It can be, by the way, local or it can be diffuse. Usually local form we see for the adults with long greater omentum. Greater omentum can come to this place and can be fused with this place of the necrotization, with the separation of the right iliac fossa from another parts of the peritoneal cavity. By the way, lucky persons, because otherwise it will be spread through all these compartments with formation of diffuse peritonitis, which is much more dangerous and we can say mortal. If it is local, we achieve finally formation of appendicular abscess. If it is diffuse, we achieve the peritonitis. A chronic process, it is a unique situation. Then instead of the necrotization and formation of the second step, which is the pus, phlegmonous, we have hypersclerotization. Connective tissues start to aggressively grow inside of the appendix. It takes some whitish form, whitish color, because of the hyper concentration of the connective tissue inside. It stands thick, and it gives the chronic irritated clinical picture. during a long time, the persons have the pain in the right iliac fossa, yeah? Then you make, for example, ultrasound, you see usually shortening of appendix and thickening of the appendix, which is should speak about sclerotizing processes. Anyhow, both is treated by the same way. It is appendectomy. You must to find and you must to remove the appendix. Again, we can make endoscopical surgery, we can make the open surgical access. For open surgical access, let's remember Mark-Bourne access. Imaginary line between right anterior superior spine and the umbilicus. The line is divided into three equal parts, lateral, middle, and medial. Point between lateral and middle thirds we call the Mark-Bourne. From this point, perpendicular to imaginary line, you make incision. Approximately 7 to 10 centimeters, 1/3 above, 2/3 below the line. Classical changing incisions, skin, fatty tissue, superficial fascia, external aponeuros, cut it by skin direction. Starting from internal oblique, you make splitting of the muscles. You don't cut. You split internal and transverse fibers. After this, you see transverse fascia, you see parietal layer of peritoneum. They also open in the direction of the skin incision. Before opening of the peritoneum, we apply, as you remember, 4 Mikulicz forceps. We lift it. By the view detection, you make small aperture. By the fingers, we enlarge the aperture of the peritoneum to not damage the structures which is underlying the peritoneum. It is intestinal contact. I make access. Now the next what I must do, recognize and find the appendix. How we do it? I see in my incision the cecum, and I see the 3 tenias, which is from the colon descended to down. You know that all these tenias in the base of appendix joined to each other because appendix doesn't have tenia. Appendix has same to the small intestine structure. Muscles absolutely equally located in the wall. They doesn't make any haustras, any tenias like in the large intestine. To say it's not the problem to find base of appendix. Much more problem to find the tip of the appendix. Tip of appendix will be found if it is typically localized. Means it has pelvic position. It passes from up to down, from right to left side. In that case, no any problem. We make so-called anterograde appendectomy. What does it mean? In front of you there are the appendix with its mesentery. First, what you do, you take the arterial forceps. Let's say this is appendix. This is mesentery. Hold it, please. Now, I see this mesentery. I take arterial forceps. I apply arterial forceps in the mesentery. I clip appendicular artery. Next, what I must do, by your left hand, please provide, no, by your pen, take the pen, provide the line here. We cut this mesentery between arterial forceps and between the wall of appendix. What after? Mesentery is separated. Now I take the, hold it, I take the ligature, I ligated the mesentery together with the appendicular artery which is inside of it. All another manipulations is more than simple. Mesentery is ligated. Now in the base of appendix, again, I put arterial forceps, little bit crush the wall to make the groove. Then 2 millimeters below this crushed groove, I apply arterial forceps. Inside of the groove, I apply the ligature, I ligated the base of appendix, then between arterial forceps and ligature, I cut appendix and remove it. After this, guys, then I cut appendix, I open the mucous membrane of it. I take any anesthetics, for example, the alcohol, or for example, iod, or for example, chlorhexidine, and try to clean this mucous membrane to prevent any infection. But that is not enough. Usually for the adults, we make so-called invagination of the stump of appendix into the wall. What does it mean? This is stump of appendix. Surrounding it approximately 0.5 centimeter far from it, I apply the round pursing sutures. Then I ask my assistant to push this stump inside of the wall and I tie these pursing sutures.
Yes.
Appendix is totally separated in the wall, not in the cavity, in the wall. For childs, we don't do it because iliocecal angle is small And if you will make this manipulation, it can make deformation of the sickle. Deformated sickle will not normally make its function, yeah? We can have the disturbance of the passage here. They say up to approximately 10 years, don't make invagination. Just maximally clean. Usually even what I am doing, I take, for example, scalpel and little bit scratch this mucous membrane. Of course, you put sterile napkin to not lose these parts.
Yes.
Yeah? Little bit scratch, maximally, for example, treated it by some antiseptics. We call it ligational method. That's why we don't make invagination, we make just only ligation. For the adults, we make ligation and invagination. It is understandable.
Yes.
But now we come to the hard situation. Base is find it, tip no. Retrocecal, retroperitoneal, some another abnormal forms. And you need to make retrograde appendectomy.
Yes.
What does it mean? Again, hold it, please. This is mesentery, this is base of appendix. Again, tip is invisible. What are you doing? Near the base of appendix, you find a vascular region without vessels, yeah? You perforated this mesentery. Through this mesentery, you provided ligature. You ligated appendix. In its base, 2 millimeters below, you put the arterial forceps. Now, between ligature and this arterial forceps, you cut the base of appendix. Again, you treated these mucous membranes. Your assistant lift the base of appendix by the forceps to not touch it to the neighboring structures. And what are you doing? Between this mesentery and between this appendix, you start to clip the mesentery now from up to down. You clip piece of the mesentery, you cut it from the appendix and ligate it. You put the next arterial forceps, again you cut it and you ligate it. How much? Up to find the tip of the appendix. It means appendectomy is performed.
Yes.
Let's say retro, it means you go from upwards to downwards.
Downwards.
If normally you go from down to upwards, now you go from upwards to downwards. Possible complications again, guys. Number one, it is bleeding if you don't normally ligate the arteria appendicularis. Number two, it is the formation of infections. Peritonitis, different kinds. Yeah. That's all. This is all information which I want to give you today. Do you have any questions? By the way, if you record me, give it to another groups also. Because last group which I have yesterday, yeah, I didn't explain them these topics.